Good morning. My name is Clara Pang, student ID 34698841. Today I'm presenting Preventing the Long Line in Home-Based Care. My aim is to show a practical plan for better at home to shorten the time people remain on the floor after unwitnessed falls and, by doing that, reduce avoidable harm. I'll start with why the long line matters in home care and how it connects to NSQHS Standard 8. Then I'll walk through a concise intervention bundle. The phase rollout, what will help or hinder us, how we'll measure success, exactly what we need to get started. Background, why the long line matters. Better at Home delivers hospital-level rehabilitation and independence care in people's homes across Melbourne. It improves experience and reduces hospital-acquired complications, but it also removes continuous observation. Many of our patients are older, frailer, and live alone for long stretches between visits, which means deterioration can occur without anyone seeing it. By long lie, I mean remaining on the floor for about an hour or more after an unwitnessed fall, or when the downtime is unknown. The risks escalate with time. Hypothermia, dehydration, rhabdomyolysis, pressure injuries, chest infection, and a spiral of fear, and the conditioning that delays rehab and increases readmissions. In a home setting, the biggest delay is usually discovery, not transport. If there's no alert or no check-in, and if the door is locked, help can take hours to reach the person. In Victoria, there isn't a single statewide time-down transport rule that puts more responsibility on our local recognition and response system to work fast every time. NSQHS Standard 8 requires a formal system to recognize deterioration early and escalate promptly. That means planned monitoring, a greater response with clear roles and time targets, a rapid response option, and a way for patients to initiate escalation. In a home program like Better at Home, that translates into scheduled observation between visits, often virtual, a single reliable triage channel, a simple escalation pathway we can execute at 2 a.m., and seamless handover if emergency services are needed. So, what's the solution? We use a bundle that tackles both parts of the timeline. Discover sooner, reach faster. First, we re-stratify at admission. Patients who live alone, have recent falls, or show functional cognitive decline are flagged high risk. They receive closer observation and a lower threshold for escalation, and they are prioritized for technology and support. Second, we provide a variable that is genuinely usable. A pendant, wrist, or belt clip with automatic fall detection, a manual SOS button, and GPS. We keep the device list short, teach it simply, test it at the installation, and check wear time at each visit. Technology helps only if it's worn and monitored, and is useful if alerts flow to someone to pick it up fast and knows exactly what to do. Third, we implement a graded escalation pathway with time targets and built-in access plan. Within 5 minutes of an alert, a nurse calls back. By 10 minutes, we verify the situation and location. And if there's no contact or any red flag, we dispatch urgent community review or call 000. The access plan is created at admission. A key safe with code on record. We nominate 24/7 key holders and consent for emergency entry. If we can't get in within the target time, we escalate. No waiting at the door. Finally, we support this with focused workforce education. Staff practice device workflows, access steps, and clear ESPAR handovers. We run short simulations, especially for after-hours scenarios, so the first live alert isn't our first rehearsal. This literature review supports the duration of the lie is the primary driver of complications. Wearable devices plus a structured pathway are associated with reduced time to assistance, and the governance layer ensures consistency and auditability. Together, these pieces shorten the two biggest delays, discovery and entry, and bring us in line with Standard 8. We'll roll this out into 3 phases so it's safe, measurable, and scalable. Phase 1 is planning and setup over the first 3 months. We confirm governance and a clinical sponsor and set up a small working group including nursing, a medical lead, and allied health. We select a device partner on usability and reliability, like battery life, water resistance, consistent alerts, and we co-design the workflow from alert to resolution and how decisions are made. We load access plans into the record at admission. We recruit 20 to 30 consenting high-risk patients for a pilot. Phase 2 is training and launch across months 4 to 6. We deliver brief practical training, hands-on device setup, plus a short simulation of the escalation pathway. We activate a 24/7 triage line and go live. From day 1, we measure a small set of indicators: alert to contact time, access success rate, escalation compliance, false positives, and client experience. Do people feel safer and find the device easy to use? Phase 3 is evaluation and scale up. We compare outcomes to baseline. Have we reduced time on the floor, complications, and avoidable ED presentations? If yes, we secure ongoing funding, embed the pathway in orientation and policy, and scale to all eligible patients. We share data and lessons across partner sites so improvement spreads. Enablers and barriers. The plan is feasible because we already have a clinical governance structure and interprofessional practice is routine in Better at Home. We also have strong patient motivation. People want to feel safe at home. Well, we do expect barriers. Some staff and patients may be cautious with new technology. Devices cost money, require charging, and can trigger false alarms. GPS and SOS raise privacy questions. We address this explicitly. Leadership endorsement, no-cost devices for eligible clients, multilingual low literacy instructions, clear consent for data use, and an opt-out pathway that still provides safety through daily check-ins or for those who decline a device. The principle is safety with dignity and choice. How do we know it's working? We will keep the measurement set small and meaningful. The headline metric is alert to contact time, and that is the clock we must collapse. Alongside that, we will track access success rate, adherence to the structured steps, and false positives to manage workload. On outcomes, we expect fewer long-line events, fewer complications such as hypothermia and pressure injuries, and fewer avoidable ED presentations. We'll also ask patients for feedback. Results go monthly to the governance so the lip stays tight. For decision makers, we can present a simple cost-consequences wheel. Device and monitoring versus avoided ambulance trips, ED visits, admissions, and pressure injury care. Even without a full economic model, the direction of value will be visible. To close, the long line is a predictable, preventable harm in home-based care. In Better at Home, the 2 levers that matters most are discovering falls sooner and reaching people faster. The bundle I've outlined, risk stratified enrollment, a small formulary of wearables, a graded escalation pathway with an access plan, and focused staff training meets Standard 8 requirements and is designed for the real-world reliability. My request today is approval to run a 90-day pilot with high-risk patients, and modest funding for devices and training. We have the governance, the workflow, and the measures ready. If we start now, we can shorten time on the floor, prevent complications, and keep our patients safer at home. Here are the references I've put into consideration. Thank you.